Great, thanks, Neil. I'd like to thank the organisers for asking me to speak today. Jean-Louis done a great job in making my talk that much easier by providing the foundation of what Mitraclip intervention involves. I'm going to very briefly set the scene for the role of Mitraclip as one of the first devices commercially to be available as a percutaneous strategy for mitral regurgitation. Take you through the key data we have, which underpins the indications, and then, as mentioned, describe the UK process, the commissioning through evaluation process for Mitraclip delivery. So, some basic facts, which of course you are all too familiar with. I'm talking to an audience that recognises this better than anyone, but if one considers how transcatheter mitral valve interventions have evolved compared to aortic valve interventions, the trajectories are markedly different, and that's certainly not, as we know, due to a lack of clinical imperative, and certainly not due to any less of investment, whether from industry, bioengineers, clinicians, but it reflects, as you know, the complexity of this valve and valve disease. It's a completely different beast compared to aortic valve disease, as you know. And mitral regurgitation is a very heterogeneous group, both in terms of the underlying pathology, in terms of the population that we're treating. And when approaching this from a transcatheter perspective, it poses a number of challenges technically in terms of how to access the valve and what strategy to take for a disease process that may involve more than one problem. And as I'll come to shortly, and you will recognize in your practice, in terms of indications for mitral valve intervention, we are seeing these devices perhaps throwing open new indications that hitherto have not had anything beyond optimal medical therapy. So the Carpentier classification is obviously highly relevant, but we've taken often a more pragmatic approach to what we're defining in terms of etiologies of MR, particularly with respect to current transcatheter approaches. And we're focusing on the degenerative and functional MR groups. And of course, from a surgical perspective, you have a number of techniques available to you to treat this valve disease. And that said, even though a number of patients fulfill criteria for intervention for surgical mitral valve intervention, we know from surveys that a significant proportion don't actually receive surgery. And the main reasons for this, as you know, are often that this describes a group of patients where the risks are higher, they've got advanced comorbidities. We're often capturing, and if we drill down into these data, we are capturing the group of poor LV function patients with functional MR. And this is where the potential new indication for mitral valve intervention, of course, is also emerging. So, as we've heard about in really nice detail, the Mitraclip is the first device to be commercially available as a percutaneous strategy. It's a right femoral venous approach through a transeptal access to enter the left side of the heart, and it's a rather sort of crude system where you have this clip, cobalt chromium clip with polyester covering attached to this clip delivery system, and that's attached to a steerable guide catheter, and you have this system of knobs which allows you to navigate the clip within the heart and orientate, as Jean-Louis has very elegantly described, using echo guidance perpendicular to the line of coaptation of the valve and orientate according to the regurgitant orifice. It's based, as we know, on the Alfieri stitch, so using a clip instead of a stitch, but not quite just bringing the edges together, but bringing the leaflet tips together and creating a tissue bridge, which may also impact on annular dimensions. And so the pivotal trial for Mitraclip was published now a few years ago, 5 years ago, the Everest II trial. And this randomized patients either to Mitraclip or to surgery in a 2-to-1 fashion. These patients predominantly in this randomized trial were degenerative MR patients, and that's important, as we'll see when we come to the population that we are treating, certainly in the UK and Europe. As has been described, the anatomical criteria, which are key in terms of assessing feasibility, were very rigorously defined in the trial. And they do focus on regurgitation that originates from the central part of the valve. And so a number of morphological characteristics can be defined which should indicate technical success when we're looking and assessing the underlying valve pathology. If we look at the Everest II randomized trial data, that there is a separation between surgical and Mitraclip groups in the first 6 months when we look at the need for reintervention, Mitraclip or surgery. We do find, however, that Mitraclip does significantly reduce MR. It's not as effective as surgery, but we do see demonstrable clinical benefits in terms of reduction in NYHA class and, interestingly, also LV volume dimension changes. And that's summarized in this table here. And these data show, the 5-year data were now published last year, and they show that there's certainly durability when we look at this patient group at 5 years. There was also a high-risk registry arm to this study, which looked at a high-risk population with high STS scores, and as you might predict, this reflected a greater proportion of functional MR patients with poor LV function. And again, it did show similar benefits in terms of reduction of MR and improvement in symptoms. And so the randomized trial certainly provided a basis in largely a degenerative MR group for arguing that there were clinical benefits. It was safe, so that the adverse outcomes were low, and they would appear to be durable to 5 years. If we look at how Mitraclip has rolled out outside the US commercially, and we look at the DMR and FMR proportions, it's exactly the opposite. So we've got predominant functional MR patients in whom Mitraclip's being implanted. And we do have registry data from Europe, which again demonstrates reduction in MR, not as effective as surgery, but it does produce clinical benefits, so improved symptoms, reduced rehospitalization. And this is recently data published by the Brompton group involvement as well in JACC last year, which also bears this out. It does tend to show, however, that in the FMR group that we do tend to see more repeat hospitalizations compared to DMR. As one might predict, it's a muscle problem rather than a valve problem. So what can we say in terms of indications for Mitraclip and where we might go from here? It certainly appears to be safe in a fairly diverse population group, both degenerative and functional MR patients. And if one follows the Everest criteria, the anatomical criteria, certainly the success rates are high. The European experience and the high-risk registry data could be regarded as hypothesis generating with respect to functional MR patients. And I guess this is an example where technology to a certain extent has outpaced the data. We know this is a group of patients whose prognosis is bad. We know that they're not patients who conventionally receive surgical intervention if they don't require cardiac surgery for any other reason. When they've hit optical medical therapy and received cardiac resynchronization therapy, these data suggest there might be some benefit to be gained in terms of symptom reduction in this group of patients. And this has really formed the basis of randomized control trials which have been underway in the US and Europe. The European ReShape trial, unfortunately, was halted end of last year, beginning of this year. The COAP trial is recruiting in the US, and there's the French Mitral France trial as well, and we wait to see what those data show. And as far as the heart failure community is concerned, there's still a lot of reticence to embrace Mitraclip in the functional MR group, and certainly a lot of my colleagues are looking for more robust data beyond the registry studies we have already, and we can discuss that later on in the discussion. So, in terms of the European guidelines, and this really underpins the UK guidance for Mitraclip implantation, it has been incorporated in the guidelines now for both degenerative and functional MR patients in the high-risk population for whom surgery is not going to be an option, or the risks are regarded as too high risk. Basic requirements naturally for any such intervention, that life expectancy is at least a year, and obviously it's technically, anatomically suitable for Mitraclip. So where are we in the UK? Well, those of you who might be familiar with the course of Mitraclip will realise how it has really reflected the challenges generally we've seen in introducing new cardiac technologies and new technologies generally in this country. And there's been very much a stop-start over the past 5 years. With Mitraclip, we saw a first wave of few centres who were able to muster together some funding to implant Mitraclip cases, and you see that peak of 83 back in 2010, and then it rapidly dropped off as we had no formal funding stream. NHS England has now approved, through an evaluation process, 3 centres in the country to deliver Mitraclip, and that includes centre where I work in Manchester, UHSM, Royal Brompton and Bristol Royal Infirmary, and we've been commissioned to deliver 40 cases per financial year. Commissioning through evaluation, so it will be heavily linked to data, and NHS England will make a decision at the end of this process, the length of which is not entirely clear, as to whether Mitraclip will be formally commissioned, whether they'll continue to evaluate, or I guess whether they might halt the process altogether. So we're capturing FMR, DMR patients. The heart team is absolutely pivotal here, composition of which has to include a mitral valve surgeon and indeed heart failure physicians to cover the spectrum of patients that we're going to be assessing. And as we've seen, echo assessment to ensure anatomical suitability is important. Exclusion, very little in the way of exclusion. However, this reflects more the learning curve more than anything else. Certainly hemodynamically significant mitral stenosis, rheumatic heart disease, where we see leaflet degeneration, evidence of perforation, they're definite exclusions, active endocarditis. But in terms of anatomical criteria, the Everest criteria certainly reflects early development of this technology, and we have seen practice elsewhere in Europe which suggests that more complex criteria might be treated. Certainly as early starters in this program, where we're commissioning will be linked to evaluation, we are taking a very rigorous approach to patient selection to define the groups that will respond to Mitraclip. This is clearly important in terms of how this technology rolls out in this country. And so we'll be evaluating patients, looking at both imaging, functional assessment, biomarkers, hemodynamics to determine suitability, but equally to understand which group of patients do and don't respond. And the important principles, the general rules, of course, apply. Your technology is only as good as your patient selection. And as we've seen in all patient groups where we look at new technologies, we need to take a broad look at the overall condition of our patient and exactly what we hope to achieve by intervening on their mitral valve. And there will be a number of factors which clearly will sway against patient suitability. So to summarise, Mitraclip, safe and effective. It's the first in what we're going to see is a long era of innovation, and we're going to see great developments in transcatheter therapies. very, very contrasting to surgical experience where we're taking this segmented approach, which of course you are not used to at all, and which limits the applicability of each individual device. And I'm sure we'll be hearing more in the following talks about the scope of transcatheter mitral valve repair techniques. It does raise the prospect potentially of combination techniques, although that carries its own challenges. And as far as the FMR group is concerned, we potentially might be looking at a broadening of indications for mitral valve intervention. How does this fit in then in our portfolio? I like to see this very much as complementary, and surgeons and the transcatheter intervention cardiologists work in a very collaborative fashion to try and tailor our treatments to the individual according to more nuanced description of an individual's aims and expectations as far as relieving symptoms is concerned. And again, we can discuss this more later on. So I'm going to end there, and I think we hand over to our next speaker. Thank you.